Bonjour à tous.
Hello, everybody. Thank you, first of all, to Guy Valancien for inviting me. It's an honor, especially as with this very varied round table, which is going to enable us to talk about the subject in detail with all of the different stakeholders. The subject we're going to talk about for the next 40 minutes is a huge subject, from care facilities to the home, working together, or how we can work together, rather. We can see today that 80% of French people who are expecting from public policy and encouragement to have home care. We've seen an acceleration in the number of outpatients, and we can see that it's important and necessary to use the home more and more. But as we take as all these changes take place, we could have some accidents. So today we have tools and have solutions, lots of different solutions. Of the CPTS, HACD. We have lots of different territorial players working with the patients. The challenge isn't really to create legislation. This is the impression I've had after talking to each one of you, but rather to scale up. There are local initiatives that are very interesting, but that aren't necessarily always possible to reproduce, and very top-down approaches don't really work. What emerges from this? There are three dimensions which I suggest we talk about, which are, first of all, how can we accelerate the care pathway by increasing coordination and collaboration and more communication. Before we look at what's happening in France, I suggest that, first of all, we start with the point of view from outside France, from Denmark, with SMETANA, who is the health attaché at the Embassy of Denmark in Paris, and who has a point of view about what is happening in Denmark, especially with the health agreements taking signed between the different stakeholders and the health centres that have enabled to make it possible to reduce saturation in hospitals in Denmark. Yes, thank you very much. It's a great honour to be here. First of all, to give you an introduction, first of all, to talk about a country which has a public health system. We have 5.8 million people in our country, and access to health care is universal and free of charge in our country. To talk about these health care agreements, the health care centres we've created between the three main players in Denmark, which is the hospitals, the GPs and the municipalities. Since 2017, Denmark has completely transformed its healthcare system, which was previously centred on hospital and is now centred on primary care and prevention. Three strategies have played a central role. First of all, we carried out a structural reform. Instead of having 14 departments, today, since 2017, we have 5 regions working with the hospitals and also with agreements with the GPs who work in the community, as they do in France. Instead of having 300 municipalities before 2017, today we have 98 municipalities who are responsible for prevention, re-education and home care. Another interesting point is then in 1989 we had 200 hospitals. We have 40 hospitals. We have 21 hospitals with A&E centres. We are creating health care centres with these main players. The GPs play a role as safeguards within the Danish system. They treat 9 patients out of 10, and the municipalities in Denmark have 50,000 inhabitants, in the same way as you're doing in France. You're also creating healthcare centres working with home care, and we have transferred a lot of healthcare professionals in 2017 towards the municipalities. So that their skills are better used, and so their size is on a human scale. In 2017, we had a series of agreements between the different stakeholders who met at the political level and at the administrative level. And I remember in 2007, there was a lot of suspicion between the different players. Each one thought they were the most important player in the system. I think that now, 15 years later, there's more respect between the different players, and I can tell you that Denmark has come out of the pandemic very well. Maybe we haven't finished yet. And that, of course, is thanks to the tests, the fact that we have a digital system, and also because the different stakeholders have learned to cooperate thanks to these healthcare agreements. The healthcare agreements say that the citizens who fell between two stools before, such as people with chronic diseases and the elderly with multiple diseases and people with psychiatric disorders. So in 2021, after the major reform in 2007, we said we need to co-create a lot more with the patients. So we decided to create these healthcare centres. Instead of having these healthcare agreements only, we 21 healthcare centres with these 21 major hospitals. So 5 regions, each one of these 5 regions has 4 or 5 healthcare centres. In these healthcare centres, in these 5 regions, the patients representing patients' associations are also represented. What's interesting is this responsibility of the community. It's much easier to understand each other's needs when you're working with the municipal level. It also makes it possible to work together with these targeted patients, and also makes it possible to have a useful medical data. I won't talk for too long about the healthcare data, but since 2003, we now have a national platform where patients have access to their own data in the same way as the healthcare protection professionals. We also have a platform where all of the medicines and drugs are available to the patients in the same way as the physicians. And this platform is very useful for telemedicine. The pandemic demonstrated, so we do more than 50% of treatments are in outpatient, and maybe we thought we were doing too much, but we carry out checks, so the patients carry out checks on themselves at the home. So there's been a big increase in telemedicine in Denmark since 2013. We started using telehealthcare with the different teleconsultation booths in the north of the country. And one of the regions carried out an assessment, and we started with the COPD patients. Another region did telemedicine in the area of psychiatric disorders. We are in the process of developing this nationally. So we didn't want to say this region is specific and we can't use your experience elsewhere. Before 2007, that's how we worked. We carried out loads of pilot projects, and then we said, no, we can't apply that anywhere else. That's now finished. We now apply the results of pilot projects nationally. We now have a national IT infrastructure. We have a services center to provide logistics support in one region which looks after the 5 regions, and we also work with the private sector. Although we have a public sector system, we have a very strong collaboration with the private sector as well, which also took place during the pandemic. Telemedicine is very well perceived by patients and also by healthcare professionals. But of course, previously, we had a lot of discussion about humanity and technology. But I think the answer now is that we need to have both. As we have closed a lot of hospitals and now people have to travel further to go to university hospitals. A lot of our patients who prefer to stay at home rather than spend time in public transport. And I have a lot of examples of how telemedicine and telehealthcare works. What's also interesting is the combination in Denmark with telemedicine and home care and home hospitalization. If I remember rightly, there are also tools that have been set up in a cross-discipline manner. These tools are easier to set up because it's a small country. You have 6 million inhabitants, so it's like a French region, quite a small country. And so this link between telemedicine and hospitalization in the home. If we come back to France, we could say that hospitalization in the home in France today, bearing in mind that you're talking about care facilities and health practitioners working in the home, we need to see how home hospitalization can make a contribution, as we've seen in Denmark, to improve efficiency, to have better links between the different stakeholders. And Isabelle Huppert, you were a minister. Elisabeth Huppert, you were a minister and you were president of the French National Federation of Home Hospitalization organizations. Do you have a point of view about how home hospitalization could provide this link and increase efficiency? Well, apart from the correction about my first name, first of all, I don't think I heard the lady talk about hospitalization at home. She talked about an approach which is a home care approach with the involvement of a lot of healthcare professionals. I'd like to correct one mistake. Home hospitalization isn't what, it doesn't correspond to what the lady was talking about. She was talking about home care, and home care in France is not intended to replace all of the home care activities. I hope that will never be the case, and otherwise the sickness insurance funds would be extremely unhappy if that was the case. What I would like to say about home hospitalization is that we are a small segment. As I often say, we are a gateway and also a hybrid animal. We belong to the air and the earth. We are a mammal and a bird at the same time. We're in both sectors. And this gateway aspect, the aspect of belonging to care facilities, makes it possible for us to take care of extremely difficult patients, which are very complex in terms of the treatment they need, and who are also not only complex, but also require a number of prerequisites to be met. So the healthcare professionals have to talk to each other, which is useful when you're working in the area of care. They have to cooperate. We also have to evaluate the situations because, I repeat, not everything can be dealt with by home hospitalization, and very fortunately, the CPTSs are being created. We also have care teams who will be less complex and more flexible, which will enable the freelancer professionals to work together. We are working on an evaluation to make sure that this is something that will be part of the and linked to the hospital system and linked to that. Now we have the last thing, which is a multidisciplinary aspect. When we have a patient that needs to be treated, we look at it from 3 points of view. We're not cleverer than anybody else. It's just perfectly necessary. It's part of our organization. It's our legislative texts, which are very appropriate in that way. We have to have a medical evaluation. What is a treatment plan? What is the patient? What is the specificity? That means we need to intervene. We have evaluation of the caregiver. We have a project for the treatment. What sort of nursing care will they need? Do they need rehabilitation care? Do they need other kinds of care? And the third point of view is psychosocial. In other words, we look at this patient in dimension in terms of their home environment. So very often we say to the conventional hospital practitioner, careful, don't do the evaluation instead of us. And this is why we are sometimes sometimes criticized rightly for being a little bit too proactive in our work, because we go and visit the patient at the home. And so, if you like, home hospitalization is one segment. We take charge of 160,000 patients a year, compared to the millions of patients that exist. So it's quite a small sector. What I want to point out is that I hope we are on the beginning of a major reform. I think a number of people here in the room who will be at Le Mans. We're going to be there at 10 o'clock and leave at 5. If anybody knows here what's happening, I'd be very grateful, because we don't really know. Well, what I hope is that this Health Refundation Council, SENA, will enable us to have something like Denmark. In other words, it'll be a springboard where the stakeholders will meet up, although we've already met up many times in the past. Perhaps this will be a good opportunity and the right day and the right configuration to move on more proactively, so that we get out of our tunnel, of our racing course. So it's true that previously we never really talked to each other between the different sectors. We're no more virtuous and we're not cleverer than anybody else, but it's just inherent to the way we're organized and what we do. You have mentioned the CPTSs. I am one of the people who has put a lot of hope in this organized form of organization of freelance healthcare professionals. I put a lot of hope in the coordination. And why I'm talking about these two systems, this means that at last, after a very Jacobean approach and very centralizing approach, I'm perfectly willing to admit I made mistakes and to say that the regions have to play a prominent role. When are we going to be able tomorrow to work with people who will meet up and maybe have been complaining at their level, but the level of a territory will agree to help certain people so that each person is able to benefit from the best possible care. So the challenge is home hospitalization to be better known and more used. Perhaps this goes through the link between the hospitals and the HAD. Lamine GHARBI, you're president of the Federation of Private Hospitalization. What are the barriers that need to be brought down for this home hospitalization to be accelerated? We make money. I know that's not a very popular thing very often, but I'll try and take things from the point of view of the public sector and providing a public service. And I'd like to thank the previous speaker this morning, who talked about the important role of the private sector. Yes, we work in one of those 5 areas was cancer. So we have to work together. 6 years ago, around the same time, in Bouza was talking about silos. And now I have some information for you about Monday, which is that when our minister invited us, some of us individually, I thought it would be a small group to prepare for a nice day. In fact, going to be 450 of us. That's going to be a nice organization. The question you asked me is, how can we improve things? What are the barriers? First of all, not everything is going badly. I'd like to Benoît Kouchner's presentation. I thought he's going back to a time I'm familiar with, but things have made progress. We have the impression that we have terrible problems, that everything's going badly, and we're all... and it always rains when we come here as well. I was hoping to have sun, but we're getting rain. But everybody's in the room, therefore, because it's raining, which is nice. So how can we improve things? Let me take a concrete example. I'm one of the first in my institution of creating home hospitalization in business. 70 patients benefited from it. I thought I'll try to go to do this in Montpellier. I brought together 150 physicians in my institution, and I talked to them about home hospitalization. They weren't familiar with that. This was 2 weeks ago. So I thought this is good. At least the local competition in Montpellier won't benefit from my patients in the clinic, and they won't start using home hospitalization. So how do we approach the situation? We have to keep the COVID spirit. We're a commando. We use our smartphones. We have to talk to each other. The physicians in charge of home hospitalization have to go and see their colleagues and explain what it is. There are two aspects to the home hospitalization. The first thing is families. Often families don't want to see granny or grandpa in the middle of the living room with their tubes and their hospital bed. There are other problems. I won't talk about those with Elisabeth. The first barrier is the families. I'm just teasing you because we said we would tease each other. We're going to talk about life because life is beautiful. The first barrier is family. The second barrier is the GPs, because for them, HAD, home hospitalization, doesn't concern them. So what I say is we have to remain simple. We have to simplify. If you don't simplify, at our level of organization and planning, I don't like it when we say that the health system is not doing well. I'm one of the active players in this planning system. I've been in the trade union for 30 years. I'm a trade unionist. I'm not a state planner. If you talk about the state, the complexity of the reforms, etc., it's another layer, as was already said this morning, with all the different organizations, the GTOS, the DDS, etc., and in the health ministry, the minister can't do everything. So it's up to us in the field to take charge of what's happening. You said you have the pharmacists and the liberal professions, health care professions. We have to double the number of patients benefiting from home hospitalization. I saw that there were a lot of tests that are going to be carried out. We don't want to start doing that. We need to keep our approach that we had during the COVID. I want to simplify and also say the gateway to the hospital community is important, and we have to keep our COVID spirit. And I'd like to thank Guy by saying that we need to work all together. It's not just a slogan that doesn't mean anything. I'm really tired of people working each in their corner. If we don't all work together, that means we've forgotten about COVID. We no longer wear masks or anything. And this is human nature will all be stronger than pandemic and by laws which are constantly making our life more difficult. So working together is also with the healthcare professions in the community. There are many healthcare professionals who are freelance in my federation. It's not always easy. I'm starting to get people throwing darts in my back already, I can see. This is also one of the challenges of local approaches, because you can't have a top-down approach. It's a whole number of local initiatives that work and consolidated. I'd like to hand the floor now to Sereine MAUBORGNE, who was MP in the VAR previously, and also a physician in the community. So we're talking about this local coordination. This is a key success factor. How can we do this? Do we need to have an extension? As we said earlier today, we said there's not only the physician and his coordination of the first-line medicine. They have to involve the nurses and the nursing assistants. Do you think there's a role for freelance healthcare professionals to play? Yes, of course. First of all, I think there is a kind of paradox today. If we're talking about the links between hospital and the community, all of the healthcare professionals work first and foremost in the hospital. That's where they were trained. They did their training there, and so they've all been through the hospital at one time or another. It's our home, if you like. And so we realized during the COVID pandemic, even the freelance healthcare professionals wanted to help out in the hospitals in addition to doing their normal work in the community. So that's one question. The second question, I'll go back to what Lamine GHARBI said. We can't consider that the issues are not the same. For example, when you're talking about public-private centres, where the private sector is in trouble, for that example, that's my problem locally. I have a problem with the local private clinic, which is working with the public hospital. The reality is that we are starting to kill public hospitals because we're not helping the private sector. The problems of the private sector are everybody's problems. And so, therefore, the problem of the freelance healthcare professionals in the community, because they don't have anybody to meet their demands. We're starting to have a territory where we have 500,000 people visit our territory every summer. The richest people in the world come to our area, and there's no organization of healthcare that is worthy of the name. So this is very important as we're talking about the patients of tomorrow. This is why I think not only should we use CPTSs, because they are an important source of help for all of the healthcare community, whether it's public or private or inside or outside the hospital. In addition, we have to ask them for their own solution. I'm thinking of the problem of unscheduled healthcare centres, which came out of the hat with the arrival of the new health minister. I've worked on this because I was lucky enough to be re-elected, and so I was able to participate in the joint effort of the agencies this summer. I worked at the hospital in the unscheduled healthcare centre, which was incredibly efficient, thanks partly to the practitioners from the private sector hospitals with their patients who were leaving to the Mediterranean that came to help us and to give us a backup. That was great. So we have some extraordinary experiences, but the implementation with the players in the field didn't happen. And today, if I had something to say as an ex-MP about the role of caregivers, because I'm a caregiver and I've always been a caregiver, even when I was an MP, you have to stop forcing people to use certain systems. You have to take a step back when you have a good idea and think, how can the local caregivers be able to put this in place? If we had put the fonds FIRs at the availability of the local nurses and say, okay, you're going to work in the CSPT as well, because we need you to get to meet people who are freelance and people who are working in the hospital. If we had said to the nurses who are in the unscheduled healthcare centre, we're going to put you in the hospital with the same level of daily remuneration, we would have created a real momentum. That's one of my regrets. Today, we don't take a step back and say, okay, we are talking about adults. Healthcare professionals are adults, and we need to ask them how they see this new tool that we can make available to them. The idea of the link between the hospital and the community is that, in my opinion, the chronic patient, as was talked about a lot today, this can be a great factor for creating links, whether it's oncology or chronic diseases. They too can help to establish a link between the community and the hospital. I don't think we use them enough, and it can be a very positive factor. And I agree with the optimistic attitude of Hélène Lagarde. But we also need to give them the right tools, and to do that, we have to have a good communication, because the local players don't always have perfect knowledge of the local range of care that is available. So I'd like to have a note to Benoît, who is General Manager of the CH Sud Seine-et-Marne Hospital, President of the MNH, Mutual Insurance Fund. We have the impression that some of the local initiatives, the success of the local initiatives depends on a few people who are drivers for change. How can we scale up without being a top-down system? Are there good things that can be applied? What is your point of view there? Well, very clearly, yes. There are lots of good things happening everywhere. What I take away from what I've just heard from this, what I've heard from the other speakers, might disappoint some of the audience. I don't go against what has been said at all. I have two co-speakers who wanted to animate the discussion a little bit. I'm not going to participate in that. I absolutely agree with what has been said. I heard somebody this morning said they wanted to go skiing. I don't want to go skiing. I don't want to go skiing, especially when I heard what was said by our Danish colleague, without wanting to annoy the president of the FHP. I think we have done quite a few things. We have tried lots of different tools. We have tried lots of different mechanisms. I heard about the use of a method I hadn't seen at Elisabeth, which is public self-criticism. I think we have put in place a lot of tools through the different laws. It's easier to criticize yourself rather than let other people do it. So we can see there are limits to our action. So there's an important subject here, and I think there are many of us, even if there are 450 people, we hope this will produce something, and on next Monday we'll be able to take action based on local initiatives, and a lot of stakeholders will be able to act as a relay. I can say that from my professional experience in the area where I work, we have lots of hybrid solutions, and we can find solutions sometimes in our toolkit, which is already available and which we sometimes forget about. In the public healthcare code, there are lots of solutions, and in the provisions of the public healthcare, we've forgotten all of these tools. So that was in a law, that was interesting, and then we forget about it. I don't think we have to have yet another reform with the name of a minister on it. I think we need to take the approach that Birgit mentioned and talk about local solutions, and the rationale that was proposed by somebody who wasn't a minister in the summit and who's now a minister, to have a system of toolkits. And then I think we can organize ourselves in the different territories. Let me talk to you about my local experience. I work in an institution where we have done things that are rather unusual. Three examples. We are participating in home hospitalization. I participate in the association of which my colleague is president. We have a home hospitalization system which was about to close. We only had 10 patients. Now they have about 80 patients. It took 6 or 7 years because it's a public hospital, so it took a while, slowly but surely. So we decided, talking to the community healthcare professionals, we applied something that was made available to us, in which they agreed to use, and it was mainly ladies. I'm on the board of directors on the CPS, and they are able to participate in the board of directors as representatives of the hospital. We have discussions with them every day. The availability of beds in the hospital is known to the CPS, and that way we can know whether we made a mistake or not. I can give you another example. We have an operator, which is a commercial operator, which disappeared 400 meters from the hospital, so we had to reorganize. We set up a CGS where we welcome the healthcare professionals in the community who work with the hospital physicians. That's nothing new. It's in the public healthcare code. Occasionally it annoys me slightly when I hear people who are very intelligent, much more intelligent than me, explaining to us that we're going to provide a solution that comes from I don't know where, whereas in fact we are able to do it already, and the process is already underway in local areas. So we need to stop having the centralized approach and have a more decentralized approach, and we need to involve the local politicians as well. I'm very keen on that, by explaining things to them, because if we do what our Danish friends did, and we have to return to this reorganization of healthcare, if we don't involve the local politicians and explain to them, it might be a problem for you to change the location of activity or to consolidate activity activities, and we will have good coordination and better collaboration. If we explain how it works, they will be in favor, instead of just switching off the light and seeing what happens. I think we should be given the initiative, and we should be entrusted with this kind of action. Each person works in their own field, and that can be a problem. I think we have a window of opportunity. We have to get out of our specific fields and think very clearly. I think we have to decentralize the hospital. Unfortunately, we're making it more and more centralized with different tools, including the territorial hospital groups. In fact, we're now looking at our navels. We have to go beyond that. We have to go beyond these limits and to be able to organize things better. I'm very clearly, I can confirm I don't want to go skiing, because I think there's a window of opportunity in the next few months where we might be able to change the situation. Yes, this is a question of organization and communication as well, so that people at the local level know what exists, and so we can give them the solutions, digital communication tools, for example, so they can have access to the availability of beds in the local hospital, for example. And could this dialogue start at the healthcare refoundation meeting next Monday? I don't think we should wait. We said we're all waiting in the territorial level. I absolutely agree with the example given by François Barne with the toolkit. In the toolkit, we have all of the tools we need. But the toolkit is disorganized, and there are people who have been able to do things with it nevertheless. What I expect from the Refoundation Council is that we don't want to do things at the national level. We need to have a roadmap for use of big data with the regional health authority managers. We haven't talked about this very much yet today. I very much believe in the role of the directors of the regional health authorities and the territorial delegations. There are departmental delegations, and these delegations need to be mediators and facilitators to do what you described, and you're perfectly right, so that there are forums and places where people meet up and they say, oh, I thought it was somebody who was no good, but in fact he's fine, he has some good ideas. The politicians as well, we have to get them to moderate what they say, so they don't start trying to take medical staff from one region to bring it to their region. That's the sort of thing we need to do. I have quite measured expectations from the Refoundation Council. My Health 2022 wanted to set up territorial healthcare centres, and if we were to use these healthcare centres properly, they could be very efficient in terms of territorial relations. I agree with what Elisabeth said about the competition. When you have a shortage, this creates competition between the territories, and that's why it's very important to allow the politicians to give the citizens and the patients make sure the politicians are made responsible for what happens in their territory and their region. And so they don't just look at their own territory, but they look at a much broader level, a much broader area, rather than looking at things town by town. Otherwise, you cause competition between different towns and different regions. What I expect from the Refoundation Council. Thank you for the support of the private clinics. What is the COVID spirit? It's creating a link between the mortal and immortal. It's not easy, but we can do it. We succeeded during the COVID pandemic, and this summer in the A&D centres, you said, Elisabeth, the regional health directors have to act as policemen, and when we go off track, they have to remind us that we have some rights and some duties, and we have to respect that. That is what the COVID spirit is, altogether, with everybody the same rights and duties and the same missions. So I also think it's good to have exceptions. For example, we don't have any hospital pharmacists. Let's find somewhere else. So let's use the people's skills. We don't have enough physicians. Are we going to continue complaining? No. We have to be inventive, and we create exceptions in the different regions so that we can make exceptions to the rules. If we don't have enough nurses, we can try and find some nurses elsewhere, and we have to find pragmatic solutions. You have to use the COVID spirit. I have two roles, as you've understood. You have to explain also there's a main financial backer, which is the Social Security, and there are also the mutual insurance funds who have a role to play in the system. Several times you asked a question about communication. And it's true that we have to communicate to our members of our mutual insurance funds to explain to them, and some of the players do this better than others, to explain to them what are the possibilities in their territories that we can give them and the support we can give them. For example, if you're talking about keeping people at home for home care, mutual insurance funds have a real role to play that others can't play, and they can provide co-funding to facilitate the treatment pathway for patients who are in home care. So all we need to do is put away the toolkit, and everything will be fine. We need to put the toolkit in order. We need to organize the toolkit, and then we can use it properly. Now, I have one more question: is what are you expecting from the Healthcare Refoundation Council? In one word. If we would like to have an ambition or an objective for this council, we explained what we wanted to do. We need to be able to have exceptions from the rules. We need to set a heading. Thank you very much.